Good morning, everyone. Well, it's morning here in California, whatever time zone you're in. Thanks for joining us. We welcome you all at our Health for the World webinar. Palliative care is key to an equitable global response to COVID-19. I am Ankur Barija, faculty in the Department of Medicine here at Stanford University with expertise in geriatric and palliative medicine. I'm really honored to welcome our esteemed panelists today, truly global experts and visionaries in our field of hospice and palliative medicine. I start with, well, one of my mentors and friends for many years, Dr. Jim Clary. He's currently the director of Walter Center for Global Palliative Care at Indiana University, and also the director of supportive oncology at IU Cancer Center. He is internationally renowned for his unrelenting advocacy for access to essential medications for cancer-related pain globally, and much, much more. I can go on. Thanks, Jim, for joining us today. Next, we have Dr. Stephen Connor, who is the Executive Director of UK charity Worldwide Hospice Palliative Care Alliance, a global alliance of 250 national and regional hospice and palliative care organizations in 92 countries in official relationships with the WHO. He has worked in palliative care continuously for over 41 years as a researcher, licensed health psychologist, consultant, and an executive, held various positions in hospice organizations. And really, it's an honor to have you join us, Dr. Connor. And next we have Liliana De Lima. She is the Executive Director of International Association of Hospice and Palliative Care for almost 20 years now. For over, what's that?
More than that.
For over 30 years, she's been supporting and advancing palliative care initiatives, initially in Latin American countries, and now internationally, working on policies in low middle income countries to advance palliative care. So has immense experience and expertise, and we're really honored to have you, Liliana. Thank you. And finally, we have Dr. Rajagopal, who is we all know he's the chairman for Pallium India and the director of Trivandrum Institute of Palliative Sciences, which is an internationally renowned program, an exemplar model for community-based palliative care. And he, in 2018, he was honored the Padma Shri Award by the Indian government for his advocacy in India that had contributed to the amendment of the Narcotics, Drug and Psychotropic Substance Act in 2014, critical step in India for reducing needless suffering and allowing millions to have access to pain, and has been involved in much, much more things in palliative care as a field. So thank you, Dr. Rajagopal, for joining us today. Really honored. Let me share our screen here. I will start off on a positive note here, talking about Health for the World, where we have a community of collaborating physicians in over 50 countries. I know many of you will be watching the recorded version. For those who've joined us live, we welcome you all to the session today. Health for the World was inspired by my own personal journeys growing up in India, and has been built on sort of foundation of selfless service. We call it seva in Sanskrit. And more than any time, these times remind us how we're all sort of an interconnected global family, and coming together with compassion and kindness is as we learn from each other and see how we can get involved. We will open it up with a question for Liliana. How how has the pandemic sort of affected you personally? And can you also comment on what you've seen on its impact on health systems, in particular palliative care?
Thank you again, Anko, for the invitation, and Health for All for having this great webinar, the opportunity to have this conversation with colleagues and friends in the field. Fortunately, I'm disease-free. I have not had COVID. I do not work with patients directly, so I haven't had the the burden of like caregivers and providers who are on the first line of response, or physicians working with patients like Raj and Jim here in the panel. But I've had family members who have had the COVID, and thank God they're fine and they're healthy now. Now, in terms of health systems and how pandemic affects this, it's quite complex because, and I'm actually using some of the information that was developed in an excellent briefing note authored by Afsan Badelia, Felicia Knoll, and Liz Grant for the series of webinars that we put together. But essentially what happens when there's a pandemic, the health systems have to regroup and kind of re-strategize, especially when there are the resources are limited. And we have seen this happening in many countries, including in high-income countries. So not only those that have less resources. So in those countries when there's no preparedness response or a plan in place, these happens, the response has to be prepared sort of in a patchy way, and it becomes more fragmented, and then affects the care and the ability to provide who have the COVID and those who do not have COVID. And then in addition to that, we always had and we've known this and reported this, the lack of resources that have been allocated for palliative care. So given the pandemic and how resources tend to be reallocated to COVID needs, then palliative care, has found in some countries also less resource, and with less, should I say, awareness and intention to work on the inclusion and the integration of palliative care in universal health coverage. So there's a few issues that have been raised, and I think it's also been an opportunity, and like everything else, it's always nice to know when crisis can become learning opportunities. But the idea that palliative care also was kind of relegated only for non-communicable diseases or end of life has now, it's more prevalent, I think, and there's more awareness that we need palliative care early in the course of disease, and then also for acute conditions such as COVID, the ability to communicate and the ability to relieve suffering for patients and families. So those
Dr. Connor, you want to comment on that?
Well, hello everyone. Great to be with you on this webinar. So the way it's affected me, I think personally, has been that it's actually it seems like we have a lot more work than we've had before the pandemic. A lot is going on. Remarkably, you think that, well, everyone's working or many people are working from home, that you'd have more time, but there just is, it seems to be, there's a fair amount of stress due to all of the things we're doing to compensate for the fact that we can't be with people face to face. And of course, no travel at this point, though many of us are used to traveling pretty regularly, we're grounded pretty much. On the positive side, I think it's actually brought me closer to family and friends. We're reaching out to each other a lot more. I mean, you might speak less often to your family that are not in your proximity. But because we're all feeling a bit isolated, I think that it's really actually brought us together. We're having much more FaceTime and communication with friends and family. I think it also, we're fortunate to live in high-income countries. That the stress and the environmental issues faced by many of our colleagues around the world make it quite difficult for them to to continue on. But it does, I think, give us an appreciation for life. The uncertainty of COVID-19 and whether you get a mild case of it or whether you end up on a ventilator in the ICU, it really concentrates the mind to some extent and makes you a little more aware of each of us of our own personal mortality and appreciation for the fact that we don't we only have a limited amount of time in this world. So kind of a two-edged sword in a way. Thank you.
That's well put. Our own uncertainties and realizations. Dr. Raj, do you want to comment on how COVID-19 might have affected you personally or professionally that you witnessed?
Thank you. For those who do not know me, I come from a low middle income country. In a way, I would say that I come from 80% of the world, which is not the high income world, which brings up its own problems. Personally, we in palliative care usually think about death a lot. It's not a stranger to us. What it has made me do personally is to tweak my advanced directive, which I had already made, and to make sure that the eventualities with COVID would be included there. But leaving that aside, professionally, our work did change dramatically. You remember that time in March when the world was slowly starting to shake and then turned upside down. So far, the health-related suffering that we see quite a lot has been accentuated more by the lockdown than by COVID-19. Our state of Kerala is rather famous in the way it dealt with COVID, and the way even the system worked to reduce the suffering from lockdown, still it was indeed sheer suffering. And it is going on. The lockdown has been partially withdrawn now, and now that the community spread is imminent, we are going to see it tomorrow, day after tomorrow. So generally our team's main thoughts are about how will we handle this? How will we handle the issues, particularly the financial issues that people have, our organizations would have, and the major psychosocial issues that we are going to face. Thank you.
Thanks, Dr. Raj, for that perspective. Jim, do you want to comment?
Never waste the opportunity of a good crisis is one of the words that we often hear these days. And certainly the world is facing a crisis at the moment. And I think there is an opportunity for us all. I've actually been living this COVID-19 thing since I was in Italy on February 29th, and was somewhat shocked when I got a notice from Indiana University to say I'd be going into home quarantine when I got back. And Northern Italy was affected, and China. And as Raj sort of demonstrated in his timing, it's turned upside down. So I went into home quarantine, and it really has been almost quarantine, but working in isolation somewhat. I did work on the ICUs for a week in one of our hospitals. We did have a flare-up in Indianapolis. We have actually flattened the curve, and that was critical. But the biggest impact, I think, this whole thing and where we can't let it go to waste is healthcare has re-owned care of the dying. And as much as palliative care is not just care of the dying, healthcare is actually standing up and taking care of people who are dying. And that's a very significant culture shift. I think we've actually seen nurses, and I'll highlight, as pointed out Florence Nightingale in the history, nurses have never really abandoned that duty. I would argue that physicians have abandoned greatly, and healthcare systems as such have abandoned care of the dying. And this has really put the focus back on dying as part of providing care to people. There were people, I spoke to a wife, and I remember a woman of an elderly a man who was dying in the ICU, and we could have created an opportunity for her to come and visit her dying husband. But even then, as she said it, why would I put myself at the risk of getting this disease to come and say goodbye to him? And she did say goodbye to by Facebook, FaceTime. Really quite dramatic changes. I'm doing remote medicine, and we can talk about that later, a lot of internet visits. So this is really a very disruptive time. We have an opportunity to recreate this and re-own care of the dying as part of healthcare.
Great remarks, Jim. Thanks for the shout out for our nurses, especially with the National Nurses Week here. We really honor their work and some of the best learnings. You know, myself, looking back at my training, I've sort of on the bedside, you know, watching them, you know, some of the best learnings came from those experiences. So I'm really, it's been really honoring their work, especially during these times.
I learned most of my oncology from nurses back in the late 80s, early 90s. Nurses taught me a lot, great appreciation.
Liliana, this one is for you. What would you say is sort of the essential role of palliative care right now and sort of the ongoing global response to COVID-19, both for health systems and public health organizations? Nice segue from sort of what Jim was alluding to.
There's many things, and in addition to what we've mentioned here at the bedside, and the role of the nurses and how critical their teaching for all of us has been in our lives, and in addition to the interventions that are focused on the relief of suffering for patients and families, which is, I'm not going to talk about those, but those are significant and important for palliative care and the provision of appropriate care for, as Jim said, care of the dying, and even those who are maybe with a mild disease, if they have severe suffering, either existential distress or anxiety, difficulty breathing, anything that creates severe health-related suffering needs to be addressed through palliative care. So that's one point.
That's fine.
But I can close it if you.
No, I'm ready.
So the second one is that palliative care is a component of universal health coverage. And then in times of the pandemic, when, like I mentioned before, when healthcare systems have palliative care integrated, then ensures that there's actual appropriate health care delivered for those patients and families in need. And then strengthening and integrating palliative care as well includes through, for example, telemedicine, like Jim was mentioning for patients, also the resilience and relief of suffering and the ability to communicate for those patients who are isolated, either at home or in hospitals. There's been a significant impact as well due to the lockdown measures, and Raj mentioned this as well, how these measures have created the system of in many cases, loneliness for many individuals, and the ability to respond to that has also been impacted. How we can allow visits and community help and the ability for those who are caregivers and providers to provide care in an appropriate and also safe way has been challenging. And I think it's not the same to hold the hand, skin to skin, when you are all covered with PPE or a face mask or everything. So the ability to connect and personally make those relationships with the patient and the family members is also quite challenging. But still, palliative care, we have the ability to adapt and strategize and do as much as we can for those who have palliative care needs and are suffering. In terms of public health organizations and palliative care as well, I think the integration, which I've mentioned earlier, how can we ensure that palliative care is now integrated in the provision and health systems and policy and norms? And that also has to do with advocacy, with appropriate advocacy by civil society and academia to ensure that there's a more flow and integrated and holistic care approach to COVID patients. I was talking to a colleague just a few days ago, and he mentioned to me that he had seen, he's in Spain, and he saw at one point what he saw was again a fractured approach to care. He said a lot of the specialists that are now treating COVID-19, they don't want the palliative care people because they're focusing on getting this patient ventilated or getting it, and they're sort of he was afraid that we're losing that humanity in the response in terms of the because it's been determined by the urgency. So being aware that this is a person, that they're connected, that there's somebody's daughter, son, brother, father, mother, that we have to encompass full care for everybody is, I think it's one of the opportunities that this pandemic has put forward.
Thanks, Liliana. You make some great points as to how disruptive it has been, but it also adds opportunities. Dr. Connor, do you want to add on some of the challenges that, from a low resource setting perspective, that you may have heard of in terms of providing palliative care, and then what recommendations would you give? Can you suggest to relieve suffering both at home and in an institutional setting?
Ankur, I'm sorry, I missed something. That question was to whom?
It's
Dr. Connor. Yeah.
Okay.
Yeah. Well, I think, as you've said, that, we've had major disruption in the way healthcare is delivered globally, and in particular in low and middle income countries. And I think that's only going to accelerate over time as the virus does spread into the rest of the world. We're hearing reports from some of our colleagues that palliative care patients are being discharged out of the hospital, basically thrown out, cancer patients and others, to make room for COVID patients. There's also a fear in a lot of the facilities of actually admitting COVID patients and creating kind of segregated wards to prevent any mixture of patients with COVID and non-COVID conditions. We've had a lot of trouble, though, being able to see our patients at home. In Malaysia, there are regular police roadblocks that make it very difficult for staff to visit. They have to explain to the police over and over again why they're there, where they're going, what they're doing, even though they're essential workers and should not be impeded in that way. The same thing in Bangladesh, where we're working on a couple of projects. We have a roadblock essentially between Dhaka, the main capital, and an adjacent city that is where the project is. So literally no one can get to see the patients. And some of the staff that live there are carrying on, but can't even get paid because the funds are not, they're in the banks and in Dhaka. We've had problems with units closing, inability to get personal protective equipment, both in high income and low income countries, more so a problem in low and middle income countries. But even in the US, we've had problems with the hospice that I work with here locally. The nursing homes won't allow any visits from hospice personnel for fear that they're going to be bringing COVID into the facilities. We're having to resort to a lot of telemedicine as one of the strategies to, to overcome the situation. But, we have to be really careful. The social workers, chaplains, and volunteers are pretty much all doing their visits virtually by phone, Facebook, by FaceTime and such. And that's, we've never really quite, we're high touch, low tech people for the most part. And, we prefer to actually be physically present with patients, but I think we're heading into a world where we have to kind of find a new balance between what we do in person and what we have to do, if you will, virtually. So those are just, I think, some of the challenges that we're facing. We're seeing a lot more consults particularly in some of the bigger cities in New York. We heard from our colleagues at Mount Sinai that they're getting an awful lot of requests for consults, and the expertise of palliative care is really actually quite valuable. In fact, palliative care is really essential to the response to COVID, and I think that's, as Jim said, that's becoming more clear that that palliative care is just an essential part of healthcare response, and that includes with COVID. Though, as Liliana said, people aren't used to thinking of palliative care when it comes to infectious disease, but we've been involved in caring for HIV and TB patients for a long time, and some others now with these conditions that have severe health-related suffering potential. That's really where palliative care needs to be available. We need, and it's also pointed up how weak our universal health coverage is globally, and the need to make sure that palliative care is part of every country's response when creating universal health coverage systems and packages of care. We have to listen more to people with palliative care needs. They are the ones who can teach us what's needed, and we have to think about how we hear their voices, how we encourage their voices, so that they can guide us in terms of what the needs are that need to be addressed. We're having a serious problem. We're having to refocus a lot of our funding that was project focused around the COVID response. So we're having to, instead of doing an education project in the community or doing educational sessions, we're looking to repurpose funds so that our colleagues, particularly in low and middle income countries, can have access to decent personal protective equipment. We're seeing a lot of creativity out there in terms of people figuring out ways to make their own personal protective equipment from scratch, because you can't even buy it and the prices are inflated. But we have to train and fund and equip our healthcare workers to provide care in this sort of new way, with barriers between us and the patients with the personal protective equipment, and overcoming some of those barriers to make it humanistic care. We see a lot of compassionate community responses. Those should be encouraged. I mean, I think we're seeing, especially in lesser resourced areas, that it's bringing out compassion in people, and that needs to be facilitated and supported and encouraged, compassionate community responses. And as Jim will speak about, I think we have to have the essential palliative care medicines for treating for relieving the suffering that our patients are experiencing, particularly breathlessness, and access to opioids for treating that are key. And the ethical issues, finally, that are being brought to the fore because of COVID. It's creating a lot of ethical dilemmas, questions about whether someone would even want to be put on a ventilator, use of sedation. There's a tremendous risk also of depersonalization in this situation, where people are not being heard and not being able to talk to their families and have that human connection that's needed anytime you're facing serious illness and suffering. Thank you.
You bring up a good point. Increasing demand, but also lots of opportunity that we're seeing with primary workforce taking up the role of palliative care. I just had an anecdote. I was involved in a palliative care program with one of the New York City hospitals, that are helping palliative colleagues out there with consults in the ICU. from here in California, and I could, even though it was not as personal, there was a lot of value in having someone be there for the family members as they're, all quarantined at home. And I heard how radiologists in the hospital had taken up the job for palliative, being involved in the palliative care team as well.
That's great.
So it's just very innovative. Dr. Raj, next one's for you. I'll unmute you. I wanted you to sort of comment on, as a lot of primary, palliative care skills are being taken over by the healthcare workforce. Sort of, what would you say as some of the key things that the provider should know to relieve suffering from an educational perspective?
That's interesting. Good. Let us look at the global response to COVID-19. You will notice that it has been essentially disease focused. How do we prevent? Lockdown, prevent. How do we diagnose? Test everybody. And how do we treat? Connect the ventilator as soon as breathlessness happens. This disease-focused approach is so much more visible in the context of COVID than in all disease treatment that we have been familiar with. Stephen mentioned integrate palliative care. But it's we palliative care people who are saying that. Suffering as an entity is ignored. Your question is, what does the healthcare provider need to know to relieve suffering, to recognize suffering, to recognize treatment of suffering as an obligation? The average doctor and average nurse is not taking that as the primary duty of care. They are still taking prevention and treatment of disease as the primary duty and maintenance of organ function as the duty, not suffering. And specifically, who mentioned that as an opportunity? It was Jim, as he said. Let us also look at this as an opportunity. Now, what is presenting to us? It is such a lot of health-related suffering, all condensed and concentrated into a week or 2 weeks. Of course, the fear factor to precede that. Suddenly, somebody being snatched away from the family, isolated, with the knowledge that I may never see my family again. And did you read the note note from that famous virologist? I can't get his name. He said, I had this strange feeling, my skull and hairs were paining. And a British doctor, quarantined alone after getting COVID, says, I couldn't explain it. Every moment was agony and I was all alone. There was nobody to help except somebody who would come and leave the food at the door when he orders. Now, this concentrated agony and suffering is simply not addressed. Now, in this 80% of the world, low middle income countries that we are talking about, the very visible difference is that this priming or possible integration is at a very low level. Medical students and nursing students do not learn about it. They do not learn about pain management, communication, end-of-life care. These are all strange. How do you provide end-of-life care? By keeping somebody on ventilator and eventually disconnecting everything. So let's see this as an opportunity. I think we have to get this talked about more, that we have a duty to relieve suffering. And fortunately, let us look at one positive point. The kind of pain management, the kind of treatment of breathlessness that Jim was talking about, the essence of communication, these can actually be taught to COVID treating doctors online. we are running those courses. Only thing is, only a tiny fraction of COVID treating doctors are attending them because that is not a government plan. Thank you. But government and health systems accepting suffering as their primary responsibility to treat is the basis. And then educating COVID treating doctors is the second most important priority.
Thank you, Dr. Raj, rightly mentioned. It's really an opportunity to integrate primary palliative care skills in all subspecialties, all disciplines. Jim, moving on to medications, which are a key part of access to end-of-life and palliative care. What medications would you say are most frequently needed for the essential medications when we're treating symptoms for COVID-19 patients?
The medications we need, to keep it simple, are those that address the physiology and pathology. And people often say there's no science to palliative care, but there is great science in understanding this. And even as we come back to Raj's comment about the ventilator, there is increasing evidence that not everyone should be ventilated, and that in actual fact, it may be bad to ventilate some of these patients. So we're still in the mode of discovery. But if we look at the medicines and for breathlessness, and I really worry as this disease hits low-income countries, we have countries that report 0 ventilators or very few ventilators. Even for those who can't get onto a ventilator, how do we keep these people comfortable? So opioids become critical for the treatment of breathlessness. Benzodiazepines for breathlessness and anxiety. We want to be reducing secretions as well in many of these patients. It may actually be the production of secretions, so you may actually have to do some suctioning, which is a risky business for someone who's got the virus. That's a risk to personnel. So I think that it's the basic medicines that we use in palliative care are absolutely necessary as we move forward in caring for these patients. The other thing, and I'll just mention briefly, and it's a result of a question from Dr. Shah, I think it is, or Hardrick Shah, what do we do about future prescriptions? Keeping up our current cancer patients, palliative care patients, up to date with their opioids is a challenge. Fortunately, we have electronic prescribing here in Indiana, but I'm seeing new consultations by video, and 2 weeks ago, I was not allowed to prescribe opioids for those patients. I'm now allowed to, by a change in state regulation, able to prescribe opioids electronically for patients that I've seen by video. I can't do it by telephone yet. So we need to look dramatically at how we make sure these controlled substances are actually provided to patients, and we continue access for those people who may be dealing with opioid dependency, cancer pain. Controlled medicines are an important part of what we do.
Ankur, may I just?
Yeah.
I also just underscoring the comment from Jim that just I think it was a couple of weeks ago, the International Narcotics Control Board actually sent did a press release and sent a request to governments so that they take the necessary steps and measures to ensure the adequate availability of opioid medications, because they foresee that there was going to be a spike and an increase in these of controlled substances, not only opioids, but like Jim mentioned, benzodiazepines as well, which are needed in treatment of COVID. I think there's an opportunity here as well for the understanding of the role that the appropriate balanced approach to access to opioid medications. Now, I think with all the media and the information that has been around with the COVID-19, it's kind of been died down, but there's been so much information about the opioid deaths and the problems that some countries, especially high-income countries, are facing with the misuse and non-medical use of opioids. That kind of fear as well was spreading throughout. And I think there's also here the opportunity to raise awareness about the importance of opioids and the need to ensure the appropriate availability and the estimates to prevent stockouts and everything else that is related to access to medicines and rational use of medications.
Thanks, Liliana, for bringing that up. On that note, how do you think civil society organizations or national level, at national level, can support these global efforts for inclusion of palliative care and inclusion of these, access to these medications and so forth?
And there's several things actually, and there's two. We're all connected. There's, we do not exist in sort of vacuums. There's no, a national advocacy effort and an international. We're actually all connected. All the international efforts in terms of resolutions, any document that it's an international framework policy document, conventions, anything that it's put out by member states through the United Nations organizations and system has to have the the approval of the member states, all the the countries, and through the representatives that they have either in the United Nations office in New York or in Vienna through the Commission on Narcotic Drugs, or the missions in Geneva for the World Health Assembly at the World Health Organization. So all the efforts that we always do are, of course, hoping that any changes that happen in language on these international frameworks and resolutions and conventions and anything else have appropriate palliative care language included, or relative to palliative care is included in this documents. Now, it doesn't work if we have these documents in place and they come out, like, for example, the palliative care resolution, which was adopted by the World Health Assembly back in 2016. If we don't do anything about it, it just becomes a very nice document. So how we connect those dots in terms of what happens at the international level with the national associations, and that's where this connectedness with the regional and the local national organizations and associations and the civil society becomes critical. And we have been working quite a lot on this field. Dr. Catherine Petrus is the IHPC advocacy officer, and I know she's in the call, so I hope she'll be able to maybe send a comment or say something afterwards. But I think it's the work that these national associations do with their own governments, and it's what really happens and has an impact at the bedside, unless the work that we do results in policies that improve patient care and relieve suffering, then it's no good at all. Then, these efforts are all just paper. So I think the national associations have the duty, they cannot, not just should, it's a duty and a moral imperative to work with the governments and state departments to ensure that palliative care gets included in those documents whenever they have, the drafts that they can put in narratives and text and improve the language in those documents. That's very important, and they can work with their own governments to ensure that palliative care is included in those documents. But also, they should work with their own governments to improve palliative care development and provision and policies and the integration of palliative care in healthcare systems for their own patients as well at the national level. They should work to offer expertise and guidance on how to provide support to healthcare providers working on first line of care, to improve the availability of controlled substances and ensure that there's appropriate estimates provided, that there's integration of palliative care in the universal health coverage, that education, like Raj mentioned, is included in the curricula of healthcare professionals, not just physicians, but also nurses, pharmacists, psychologists, spiritual care providers, all professionals who are working in care. And then also for the integration as well on the recommendations made by the Lancet Commission global access to palliative care and pain relief, which includes a list of essential, it's an essential package, and that includes medications, interventions, educations, and equipment to ensure appropriate care. So I think there's a lot of, it's a plethora of steps and activities and interventions and things that we can do to ensure that there's an improvement in the relief of suffering.
Thanks, Liliana. That's really helpful. Sort of, I'm wondering, in the interest of time, run quickly over some of the resource questions. Jim, do you have comments around, any quick comments to add to what Liliana added around sort of the International Narcotics Board, sort of easing some of the regulations, but anything else, that COVID affects, or any recent changes that we need to know, our audience needs to know? Medication access.
So the challenge, and I'll stick with opioids, the challenge as we look at our history is that we have stopped stockpiling opioids because of the opioid overdose epidemic that we've seen, particularly in North America. In the United States, we've actually cut down by a decent percentage the amount of opioids we had in reserve. Most of the world's countries, 80% of the world's population, have no reserves, let alone access to these medicines as well. So that's a real challenge. While people don't have a quota, they can request opioids through the International Narcotic Control Board, and particularly in a time like this, they can actually be requesting to get access to more opioids in order to make sure that they have enough on board. This is a process that's legitimate. There is even a process that came out at the time of the Haiti earthquake that you can ship opioids to another country quite quickly in the time of a disaster. So the International Narcotic Control Board, the UN mechanism, has ways to do this, but it has to come from your country. You as a member state, a nation, has to request this. And I think that's going to be an ongoing challenge, that our ministers of health, our bureaucracies, don't actually understand the role of these medicines at this stage. So we as palliative care clinicians need to be advocating with our governments to make sure they hear this, and they need to know there is a process to get access to these medicines.
Thank you. Liliana, quickly, I know there was a recent publication just last week around which IAHPC led in the development of a consensus-based new definition for palliative care, and all of you were part of that expert group. Does anyone want to comment? And you can do it, Liliana, or if someone else wants to comment on how might this be relevant in the time of COVID?
Thank you, Ankar. I think this was a great project. All of the panelists were involved, as several of many others, and they're listed in your screen. And we're very grateful for everybody's contribution. We had a 3-phase process, and also on the second process, we had over 400 participants from 83 countries providing feedback and comments and also their opinion on the text that it was being developed. But I think the essence of these new definition, that it was a consensus-based definition, is that, and just, I'll read it here because I don't know it by heart. I should, but it says, palliative care is the active holistic care of individuals across all ages with serious health-related suffering due to severe illness, and especially of those near the end of life. It aims to improve the quality of life of patients, their families, and their caregivers. I think the essence here is the health-related suffering. It's not determined by prognosis or disease or a condition. It could be, spiritual suffering. It could be psychosocial suffering. Anything as reported by the patient and the family as creating severe suffering, serious health-related suffering, needs to be addressed by palliative care. I don't know if anybody else has any other comments, but it was a wonderful process and project.
Well, this is a time, before the end of the hour, we there's just so much to talk about, but we wanted to get experiences from various parts of the world. So we're gonna invite Dr. Veru from Nairobi to join us and talk about his experience. Give me a second. Dr. Veru, John, you're able to.
Yes, can you hear me?
Yes. Go ahead. John, you there?
Yeah, you can hear me?
Yes, we can hear you. Go ahead.
Okay, thank you. And I think that's a very great learning experience from the panelists. And as you can see, so much is happening across the world. And I guess this pandemic has brought us even more closer to each other than before. And much have been said about the experience in provision of palliative care. But I want to start from the end, Liliana's comment about the new definition of palliative care, because we are still struggling with the definition, where palliative care is still equated with end-of-life care. And the new definition actually captures what need to go in there. And as we talk with our clinicians, we are able to tell them now, look here, palliative care is not defined by age, it's not defined by any specialty. It does not fall only in surgery, in medicine, in gynecology. It falls across board. And as this become now more accepted, suffering will reduce. But now connecting this with the concept and the care for COVID-19 patients, our experience has been in the last 3 months that as we take care of these patients, initially there was a feeling that this was just an infectious disease that required only the infectious disease team. And the first patient we took care of, unfortunately, came in very late, had multiple organ failure, a lot of symptomatology because it took time to come to hospital. He was actually admitted directly to the ICU. The organs were failing, and within a few days, we lost him. And it's at that point that the infectious disease team and the intensivists called us to just come. And the reason we were called in was actually to support them. Because the pathophysiology of the disease itself was not in keeping with what they are used to seeing, even using the tools they use in ICU. So they were worried. There was a lot of restlessness within the team. Where did we go wrong? Can you assist us? How do you assist us in debriefing the team? And we took that chance and came in and told them, now is the high time that any patient who is admitted accesses and require palliative care. We were able to talk with the team members who took care of this patient. We were able to talk to the teams in ICU. We were able to talk to the administration, and then provide support to this kind of patients. Apart from what Jim and others have said, definitely there is an issue of access to medications. And our fear is we might use our quota, especially of the opioid, morphine, and exhaust it even before the year get to a half, because this is the drug that is also being used to relieve these symptoms of dyspnea and pain for these patients. And all the other issues about resources. We are limited with the resources, starting with the human capacity, all the way to the PPEs, and even space where we can utilize in taking care of these patients. And it's only recently that the institution had to come up and ask us to come up with a document of if we had the surge, we only have about 12 ICU beds. we only have about 10 HDU beds. We can convert another 8 beds to BICU HDU. If we had the surge, what would you do? What will we do? And we have to come up with a document regarding how we can guide the institution on the way forward if the surge came, who shouldn't access these critical care services. And we had to combine a few tools to see who can be selected, and multiple physiological and medical factors came into the fore. Now, apart from the challenges that we get is the fact that if you look at the patients and the families, we are a multicultural, multireligious, very communal society. And it's becoming a very big challenge that a patient diagnosed with COVID, admitted, wherever he is admitted, the family has to go to quarantine or isolation. They are not able to come to see, they are not even able to communicate, they are not even able to say goodbye for the 2 patients we've lost in our institution, and it's a very big problem. And we had to come up with ways of making sure that families who are in isolation, families who are at home in quarantine, are able even to talk to these patients. Even if it is through phone, we had to arrange that. The other challenge we had was how do we provide spiritual care, for example? Our society is very religious, and you cannot call in the religious leaders to come. And everybody had to, in a way, become a small religious leader, and all members of our team, including ICU doctors, had to become small members of the palliative care team, providing support, providing communication, which now has become key. By and large, that is about the patient. Now, going out of the patient, the issue of stigma, the issue of discrimination and profiling, when you hear that someone has been diagnosed with the COVID, is a big problem until people are trying to hide the diagnosis. People are trying not to come to hospital when they get these symptoms. And it's not only the family members, it's also our colleagues who we work with. We have a colleague who we had to actually debrief and support a lot for about 2 weeks, because anytime he left his house to come to work, the neighbors' children had to go back to their house and hide and lock, because the word out there was that he works in an institution where there have been COVID. So there's a lot of those ethical and social issues, and this might actually be a negative for the families. Now, on top of this, COVID has itself extended the effect on non-COVID patients. Clinics are running at a very low pace, 40–50% for other patients, cancer patients, diabetic patients. Where are these patients? Most of the hospitals are occupied by half-quarter clinics are not being attended. And our fear is these patients are staying at home. And stay at home without a refill of your regular medication will be a very severe pandemic to come after now what we are dealing with. It's only yesterday that we admitted someone who had who suffered a stroke because they decided they wouldn't come for a refill for their blood pressure medicines, also actively on cancer treatment, and they decided to take care of their hypertension pill in alternate days. And this just went off the roof. The other issue is now, if you look at the clinicians in general, nurses and whatever, the mental issue are also coming to the fore. Because remember, we work with these patients, even if we have the PPEs, even if we don't, we'll still go back to our families who are susceptible. What duty do we owe them? And the biggest fear is we might be protecting ourselves in the hospital, but we are still a risk to our patients when we go home. By and large, the issue of contact of the patient, telemedicine has started with its questions on confidentiality and privacy of patients' information. That is being worked on. The positive thing that has come up is now most of the clinicians are able to listen to the palliative care teams. So far, I think we'll be able to talk to our teams in the hospital, to the teams in the country. And last week, we held a webinar where the attendance was by about, I think it was more than 300 clinicians across board. They have been requested to talk more. So this is a chance to train our mainstream healthcare providers and also
Dr.
the families.
I
and the
apologize to interrupt you. I'm so sorry to interrupt you. We are at time, so we'll have to wrap up within a minute. So we're so grateful for your work on the front lines there at Aga Khan University Hospital in Nairobi, and for you bringing such important points for healthcare personnel and also for the patients. This virus definitely has been notorious to exploit every dimension of a pre-existing disadvantage, so to speak. Whether it's being old and isolated in your homes, whether it's being imprisoned, whether it's being poor, or living in an overcrowded condition. It's just unfortunate that it's just attacking the vulnerabilities and inequalities and really bringing them up to the surface. Well, these are some resources. There's the weekly webinars from the Worldwide Hospice Palliative Care Alliance and the International Association for Hospice and Palliative Care on Friday mornings at 5 a.m. California time, which have been really great. Resource by Jim from Indiana University, the new Center of Global Palliative Care, and then a field manual from our colleagues. A shout out to Marcia Glass and Aisha Shulman for that. We've got to wrap up now, but just a few words that if you Google Health for the World Academy on YouTube, you will find a channel with all multiple COVID-19 related lectures that have been pre-recorded, and also this recording and other palliative care lectures on YouTube, as well as healthfortheworld.org/academy. These are all open source and can be helpful right now as you're disseminating knowledge and resources to your colleagues who are actually taking over palliative care skills now. I would leave us sort of with this essay that came out just last week in BMJ, which really struck a chord with me in during these tough times. How the only thing that remains is love in our decisions, whether it's love for our work, our patients, or not leaving anyone behind to die alone without their families' involvement. So I thank you all for joining us today, the attendees, the expert panelists. Thanks for taking our time during these times. There's lots to talk about, obviously, and we are all really grateful for all the years of advocacy and the sacrifices and the work that you've done to pave the path for us and the coming future. So thank you all for everything.
Thanks, everyone.
Thank you.
Be well. Wash your hands.
Thanks for your time, and thank you all for joining us. Bye now.
Thank you.